Good evening, everyone.
Hi there.
Thank you for joining us on this dreary Tuesday evening for the second seminar in the Global Issue Seminar Series for the fall 2011 semester. As you can see, the theme for this semester is well-being, education, health, and global sustainable livelihoods. And so this one here, we're going to talk about health and bridging the gap between local and global. The Global Issue Seminars are a series we started last fall in 2010, co-sponsored by the School of Public and International Affairs, as well as the Office of International Affairs here at NC State. The fall semesters, we tend to do some broad thematic topics, whereas in the spring, focus a little bit more on political science and with the Great Decision Lecture Series, so we hope you can join us for that as well. The next seminar and final one in the series will be on November 8th in this room on Tuesday night from 7 to 8:30, and that'll be on global sustainable livelihoods, using innovation to drive development. And we have some great panelists for that as well. So let me go ahead and introduce our panelists. I'll introduce them all at one time and let them just run through their slideshow kind of seamlessly here. We have Peter Cowan, an associate professor with the Department of Population Health and Pathobiology. He's a member of NC State's College of Vet Meds, the department here of Population Health and Pathobiology. He obtained his BA in Sociology from Beloit College and his Doctor of Veterinary Medicine from the University of Ibadan, Nigeria. I messed that one up. As well as his MPVM and PhD in epidemiology from UC Davis, where he worked with Calvin W. Schwab, the earliest modern proponents of the concept of one medicine, and founder of the first graduate program in veterinary epidemiology. Since 1996, a particular project of importance to Dr. Cowan is his work as moderator for ProMed Mail, an internet emerging disease surveillance system recognized globally as a major communication avenue for the public health profession. He has appeared on national public radios, All Things Considered, to discuss avian influenza in West Africa, and Science Friday to discuss animal epidemics in 2001. So Dr. Cowan here has definitely got some really great credentials, and we're happy to have him here tonight. Hi. That's okay. So Marianne here is going to finish introducing our panelists. We have introduced Peter here, and she's going to start with Sophia. She's the Director of Global Health Initiatives here at NC State.
I apologize for being late. The parking situation tonight was rather challenging, and we were at the Chancellor's home, and I made the mistake of driving here. So I've been driving around for 20 minutes looking for a parking spot, and I am now parked illegally. So pray for me. Okay, I would like to introduce Dr. Sophia Cathario, who is a professor of food, bioprocessing, and nutrition sciences. Sophia hails from Greece, where she grew up in a small rural community. She has her PhD in genetics from the University of California, Berkeley, and she worked at the Centers for Disease Control and Prevention and then at the University of Hawaii prior to joining NCSU in 2000. Her interests focus on adaptations and evolution of foodborne bacterial pathogens. She has also served as editor of Applied and Environmental Microbiology, and she's been on the editorial board of the Journal of Food Protection. And in 2007, Dr. Cathario received the Heinz PR Seeliger Foundation Award. This award is given for her outstanding achievement in work with Listeria. I'd like to welcome also Dr. Annie Antone, who's a professor in computer science in the College of Engineering at NC State, where she's director of the CSC Policy and Compliance Initiative. Her research focuses on methods and tools to support the specification of complete correct behavior of software systems used in environments that pose risks of loss as a consequence of failure and misuse. This includes web-based and healthcare systems in which the security of personal and private information is particularly vulnerable. Current extensions to this work include analysis of security and privacy policies, regulations, and compliance practices. Dr. Antone is the founder and director of the privacyplace.org, a research group of students and faculty at NCSU and Purdue University. She leads this group in the development of technology to assist practitioners and policymakers in meeting the privacy needs of engineers. I'd like to offer congratulations to Dr. Antone on being named the 2011 edition of the eHow Shift 100. eHow is an online guide with more than 1 million articles and 170,000 videos offering step-by-step instructions, and recognized 100 women as the 2011 Women of Shift, a selection of 100 real women who are living their passions, embracing their interests, and overcoming obstacles by discovering the expert within. She's joined on this list by other celebrities, including Bethany Frankel, Jennifer Lopez, Joan London, Rachel Maddow, Elizabeth Smart, and Alice Waters. Congratulations, Dr. Antone. And finally, I'd like to introduce Dr. James Kiwanuka-Tondo, who is an associate professor, the coordinator of public relations in the Department of Communication at NC State. And he's also interim director of international studies in the College of Humanities and Social Sciences. He is the current president of Sigma Iota Rho Honor Society for International Relations, Ada chapter of North Carolina State University. His main area of research is health communication campaigns with a particular emphasis in HIV/AIDS. He has studied HIV/AIDS campaigns and public policy in Africa, as well as coverage of AIDS in the USA and Africa. Dr. Kiwanuka-Tondo received the award for Outstanding Graduate Teacher of the Year, Department of Communication in 2007-2008, the Advocacy Award for promoting the presence of African Americans at NC State University in 2007-2008, and also Outstanding Undergraduate Teacher in the spring of 2007 in the Department of Communications. He also received Outstanding Professor of the Year Award in 1999 from Sigma Pi Epsilon fraternity in the University of Connecticut. He has been the principal investigator on several research grants and has authored several publications and conference papers. He's a fellow of the Salzburg Seminar and a recipient of the Fulbright Scholarship, as well as the British Commonwealth Technical Scholarship. So welcome to all of our panelists, and if you give them a hand, we'll get started. So the focus of our talk tonight is on health, and it's bridging the gap between local and global. You know, we're here at a land-grant university, and most of our focus has been on local issues, and now we're finding ourselves with a chancellor who's telling us to act locally and think globally. So we need to really start thinking more globally. So tonight we're going to address issues of health that are bridging that gap between the local and the global. So we'll start off with Dr. Cowan. And the way that this is going to work is we'll have each speaker present for about 10 minutes, and then we're going to open up the floor for questions. So start thinking about that relationship between local and global health. And with that, I'll invite Dr. Cowan.
Well, welcome everybody. Well, I didn't get any welcome back. But, so welcome everybody.
Welcome.
Thank you very much. Thanks for indulging me. When Dr. McCord first asked me to talk about this in this seminar and about this subject. You know, she indicated to me that we should really bridge the gap between the local and the global and the local. And you know, she seemed very intent on making sure that my talk followed that theme. She didn't give me free license. And what it did is it caused me to think a little bit about what is the gap between the global and the local. And I've been involved in simultaneously two things. One is you know, the internet monitoring of emerging diseases, and the other is the eradication of bird flu in Nigeria. And I guess I would suggest to you that I'm still thinking about what is the global aspects of monitoring emerging diseases on the internet, and what are the local aspects of it. And then what are the global aspects of eradicating bird flu in Africa, and what are the local aspects of it? Because to me, there's always simultaneously a global and a local in every health event. And it's sorting out the proportions, it's sorting out the understanding the appropriate roles for global and appropriate roles for local. That's the key to making progress in health. So as this first slide will show you, sometimes the question between global and local gets to be sometimes a tie that needs to be cut. As you can see, sometimes health events that are tied together in sort of a global way, occasionally if somebody sneezes, needs to be cut. Okay, so traditional public health reporting, it's sort of a top-down system. It looks something like this. You go from, you know, local situations to local practitioners up to the state level and then on to the national and international level. What I'm involved in terms of monitoring emerging diseases is much more like the web, much more an internet-based information system, or what we would call in public health surveillance system. No, that does not mean spying. It has nothing to do with the dark arts, but it is a term in public health that we call close monitoring or close watching. And it looks something much more interactive, and it in truth is much more interactive. Emerging diseases, of course, is my specialty, and it's the thing that I enjoy the most. And the theory is that it's always the perfect storm where multiple interacting factors come together in order to allow for the emergence of a disease. And of course, these multiple interacting factors are going on in specific local geographies, like a rainforest, or like a place in Old Lyme, Connecticut, where people are living closer to deer than they should be, or than is good for their health. Or in, you know, a homeless shelter where TB is emerging because of poor public health conditions and a lack of public health infrastructure. And clearly, all of this means now, in the way the world is connected and the way the diseases emerge, that there really is only one medicine. And what do I mean by that? Sir William Osler in the 19th century said, there is no dividing line between the medicine of animals and humans, nor should there be. And clearly, I'm not suggesting that veterinarians like myself can treat people. You guys should be treated by physicians. There's no way I have the knowledge. But the fundamental basis of disease is really one medicine. You know, in 10 minutes I better stop there, because if I get started on that particular theme, you guys will be here all night. This is the group that I work with, and this particular post was the world's first information on SARS. It came as, you know, as a lot of blog posts or internet posts. We're really the first sort of emerging disease blog. And it just came from somebody who was very credible, Stephen Cunyon, who we know by all his, you know, letters behind his name. And, you know, he suggested that he had heard in a chat room that people were dying in Guangdong province. This later turned out to be the first information about SARS, and we know what that led to. So information comes into us, we triage it in this sort of fashion. I'm somewhere here in the middle box here as one of the, expert subject moderators, and you know, we then put out all this information on emerging diseases, and we sort of become the CNN of emerging diseases. But the interesting thing is we had a very central system, and when I started there were just 6 of us, and we were monitoring diseases globally. Remember, Dr. McCord charged us to figure out what was global and what was local. And we were really, we did a sufficient job, we grew, we became important, we, you know, 256 subscribers at CDC alone. And yet what we found in the last 5 or 6 years is in order to be more effective, we had to develop regional networks. So we have one in the Mekong Basin, we're just starting one in East Africa, one for Francophone Africa. We have a Russian network, a Spanish network. And in order to be more effective, we had to get down. We had to scale down. And it's gone to the point where we partnered with something called HealthMap, which is a mapping tool and monitoring tool in and of itself. And they're developing a phone app that says outbreaks near me, and hoping that at some point, if you see dead birds falling out of the sky, you'll call them up, you know, give them a location, and they'll be able to take in the information. Okay, so anybody who can identify me in this particular picture gets an A. This is me in Nigeria, and we're on a bird flu farm. This farm had bird flu. And, you know, I title this From Independence to Interdependence. And it should be titled From Global to Local and Back Again. Because when Nigeria got the bird flu, the head of the Food and Agriculture Organization, chief veterinarian, flew into Nigeria and said, okay, here's what we're going to do. We're going to vaccinate. Now, he must have thought he was going to Ghana because, you know, in Ghana, they don't have, you know, 7 veterinary schools like they do in Nigeria. They don't have 4,000 veterinarians. They don't have PhD level veterinarians. And the Nigerians looked at this situation themselves and said, no, we're not going to vaccinate. We're going to educate. We're going to eradicate by test and slaughter. We're going to take other methods. And it turned out that they were probably right. Now, was Nigeria helped a great deal by global experts, by resources, you know, USDA opening up their purse, China sending ships of laboratory? Of course they would. If it was not a global effort, we wouldn't have had the success we did. On the other hand, and if the Nigerians didn't know their own situation as well as they did, we would have taken off on a course that would have been greatly in error and would have been mistaken. So I'm sure I've used more than my 10 minutes. But I do think we're living in an interdependent world that is simultaneously global and local, and we have to work on all levels.
Thank you, Dr. Cowan.
I'm sure youth is on your side, so you feel a little bit more active than I am, because I came here by mistake at 7 in the morning, thinking this was a morning meeting. So I've been up, I've been up and around for a long time, too long for me. But today I would like to talk to you a little bit about issues having to do with food. So we're going to change gears a little bit. However, I think that we will see as we come to the conclusion of this that there are some rather interesting commonalities between what Dr. Cowan just mentioned and what we see as emerging themes in food safety. So when it comes to food and food safety, we often hear the term local. You know, we talk about local foods. With everything food that's local, we have also issues with health, as with any food that is not local. And as I was thinking about this title, I was thinking, you know, what is really the opposite of local when it comes to food? It's not exactly, we don't have a good word for it. I guess you could say non-local, but it's not very graceful. So global means something a little bit different to most people. It means something really distributed across all the different continents, or in many places on the earth. So when I think of local, I always associate it with a character of place and a character of culture. And that is definitely the case with foods. So in lack of any other good definition, we have a working definition of local foods and local food safety issues having a regional component to them. And anything that goes beyond that regional component, that breaches regional barriers, however we want to define those, would be a non-local and in some cases a global issue and a global food. So to come right away to some examples, in the pictures here, in the two little insets, are the two organisms, the pictures of the two organisms I spend most of my time with. So here is Listeria. Let me see if I can get this to work. Very meek and mild. This is Listeria, an organism that contaminates ready-to-eat foods like deli meats, soft cheeses, and it can cause a real horrible disease to people who are at risk for it, like pregnant women and the elderly can get a very serious disease if they consume food that is contaminated with that organism. And it's what we call a ubiquitous organism. In other words, chances are the bottom of our shoes coming in from the outside have this organism on them. It's found very commonly in the environment. And here on the left, this corkscrew-shaped microbe is called Campylobacter, and it colonizes the animals, including the animals we grow for food. So when I go to a turkey farm or a hog farm, and I've been to many to collect fecal samples to isolate this organism from, I can get this organism from any of the animals. When those turkeys, so those turkeys are grown locally. Those are local farmers in local turkey houses. It's a community they live in, a local community with a very well-defined character of locality. When those birds are slaughtered and their meat is processed, that meat, that turkey meat, can go pretty far away. It can be sold locally, but it can also go to all kinds of other places, not only other states in the nation, but places as far away as China. It's sold there. Wherever that meat goes, those bacteria go along for the ride as well. So here we go from a local product, finding a very large trans-regional distribution that bypasses the local limits, the local geographical limits. So I would like to start with an actual example of something that's actually almost happening right now as we speak. A few weeks ago, there was a major outbreak coming out of Colorado. As you can see here, these are cases of people with Listeria infections. And you can see here, most of them were in Colorado and then some other states. Altogether, 23 states. And when I sent Chantel this slide, that's the numbers that the CDC was giving. It's now 109, and 21 people have died. The source appears to be traced to cantaloupe. Cantaloupe that was grown in a set of farms in a region in Colorado. Here is the epidemic curve showing how these cases were distributed through time. And here is actually what the CDC has sent out for consumers to be able to recognize the product and throw it away or send it back, because that's the particular product that was involved in this outbreak. And you can see here several, in this label, you can see several elements pertaining to the local character of that product. It says Colorado grown and other characteristics of this particular item. So we have a local product which actually was the pride and the joy of that region. Those particular cantaloupes, that particular brand is very well known among cantaloupe fans. And it's apparently extremely sweet and very, very good. So it's kind of it's a delicacy. And this was a local product that was a big thing for that community. As you can see here in the website of this agency, of this company before the outbreak, they were talking about, they had things like Colorado Proud up there on their website. And also this was available quite readily in big local chains. However, we went from a wonderful, locally produced product that was indeed associated with the region and proudly associated to something that caused a multi-state outbreak and clearly went beyond the local barriers. So here is the issue. We have a public health problem. We have an organism that's found common in the environment that can cause very severe disease for some people and which can associate itself with specific products. And that particular combination, the organism and its ability, the produce that becomes contaminated, and even, I believe, the organisms themselves, the bacteria themselves, they were probably strains, variants of that organism that were circulating in that ecosystem. Maybe in the farms, maybe in the water that was used for irrigation or for putting pesticides, maybe, actually it's pesticide-free, so that takes that out, but maybe in the farms, maybe in the water for irrigation, maybe in the processing plant. There is another example that I would like to summarize for you. In the I chose them because they're kind of watershed events. They kind of shake us up a little bit because we are surprised about these outbreaks. It's the first time we kind of saw in the public health field both of them, and it sets the wheels rolling for a lot of new learning in the discipline. So Escherichia coli, most of us have heard of E. coli. E. coli is a rather remarkable pathogen and all kinds of interesting adaptations. So again, we have all that it takes to have unexpected events from our human perspective. So in this last summer, we had a situation in northern Germany where we had an outbreak that was actually very, very difficult to figure out. And it was not only difficult to trace, but it was rather unusual. There were many people and many deaths. More than 50 people died. Many of these people that became infected, unlike previous outbreaks with E. coli strains, were young people, people like in their 20s, people in the prime of their life. So it had a tremendous public health burden. The tracing of this outbreak was to fenugreek sprouts that were imported from Egypt. So that's why I put here from sunny Egypt, because these plants require warm and dry climates to grow well. So it went from there to a place like Hamburg, bypassed the regional barriers and became problematic. Now, the strains themselves, if one had a very close look at them, had already been circulating beyond a specific location. So we have here closely related strains from Germany, Finland, Mali, Central African Republic. Now, coming back to finish with Listeria, because it's a good paradigm, besides that I work with it, so I know more about it than most other bacteria, than I know about most other bacteria. So I would like to mention a couple of things that the bacterium itself is telling us that might tell us about its distribution itself, whether it and the foods it has been found on have been in specific places facing specific selection pressures. We have a strain that has a mobile gene cluster. This can move around among Listeria. It has genes for disinfectant that tells us processing plants, because processing plants use a lot of disinfectants for sanitation. Genes for resistance to cadmium that tells us perhaps industrial pollution, perhaps also biosolids. Genes for resistance to toxic dyes that tells us aquaculture, where in some countries these dyes are used to prevent fungal infections, and also textiles, because the beautiful clothing colors that we have, the dyes used for them are pretty toxic dyes. So we went, in this strain, went from this very quaint rural community where this plant that was contaminated is the major industry in that small community, Zeeland, Michigan, on the shores of Lake Michigan. It went to a multi-state outbreak that has changed the paradigm of listeriosis infections as we know it. And this is some information about the compounds. So to finish, I would like to say that in looking at food safety from the point of view of local foods and what they have and local issues associated with those foods to more widely distributed, we come across foods and issues. We come across some generalizations. Bacteria will respond because that's what bacteria are very good at. All life is very good at that, but bacteria are especially good, and we can see their responses, and they can move around. They can move around on food products themselves. And food is the perfect vehicle. So wherever it goes, and with our current market practices where food can go places very, very easily and very far, we have amazing potential for transfer. However, any situation that we consider multi-state or even global started from a local situation. And that's where I think these thoughts connect with what Dr. Cowan said. No matter how global a product is, how big the company or how far it's distributed, it started in a local production place. It started in a local farm or in a local situation. And at the end of the day, there's only one face in human disease, whether it's small scale or multi-state or whatever, and that's the human face. And that's why I put that comment on the left, on the right, because when we deal with human disease, that's what motivates us to learn from it, the fact that there is a public health burden associated with foodborne disease. So I would like to thank you for your attention. Good evening. Good evening. Good evening. Excellent. So I'm Annie Anton. I'm in the computer science department. And the work that I do in healthcare is actually very local in a sense because I'm looking at federal law and how do you comply with federal law when you are governing electronic health record systems. So how does that go to global? Well, I'm going to talk about a case study that we did, and that we're now going to run again in an international setting. So that's one way in which we're doing some global work. And another thing is that the work that I do in healthcare, we're also applying it for national security purposes. And so we work with several, we're working with the government and trying to figure out how the way that we manage information, whether it be about healthcare or whether it be about U.S. persons, that we want to protect their privacy, or whether we are sharing information about passengers who are traveling in and around the country with other countries, is a lot about international law and how do we make sure that we're doing information flows in a way that complies with law. So as you see, there's a lot of, although I'm talking about healthcare here, there's a lot of national security applications to the work that I'll be discussing too. So if you go and do a search on Google for HIPAA compliance, HIPAA is the Health Insurance Portability and Accountability Act. So every time you go to the doctor and you get that big long privacy notice that, how many of you read? You should read it. You should be really careful about signing it too. So if you look and you do a search on HIPAA compliance software, you'll see that the very first item here says that our software fully complies with all HIPAA regulations. You look at the very next entry and it says that there is no such thing as HIPAA compliance software. So what are you supposed to do if you're an engineer and you need to, or you have a medical records situation? Like, how do I find software that complies with law? So that's what we've been working on. So Peyton Manning recently had neck surgery in the spring, and he's been hounded by reporters about his recovery. And he had a really interesting quote about HIPAA. He said, "I don't know what HIPAA stands for, but I believe in it and I practice it." So we're getting HIPAA really into layman's terms here. And I apologize for the weirdness. I work on a Mac and the
transfer didn't work quite well. So the problem statement of what we've been working on in our group is that software engineers actually need guidance on how do you comply with law and what do we do to protect electronic health records. And it's a very, there's my mug, I love being compliant. So what makes this very difficult? If you look at law, there are a lot of things that make it difficult to parse and to understand. So if you're developing a regular system, I might go and interview one of you and say, what do you want in your system? And you'll tell me what your requirements are, et cetera. But how do you figure that out when you have to work with the law? And so law is very laden with legalese, and it always requires that you either be an expert in law or that you have a lawyer on board to help you discern and infer things correctly from the law. So what we're trying to get is to a point where if you, for instance, have a data breach, how many of you have ever received a data breach notification letter? Well, that's very good. There's only a few of us. So there's a bunch of data breach notification laws in the country. So if a company, for instance, let's say you go to, just to pick on another ACC school, Duke Medical or UNC Medical, and your records are in some way breached, they have an obligation to notify you within a certain amount of time that your information has been breached. There have been cases in which companies have had data breaches or they violated their privacy policy or violated law, and they get hefty sanctions from the Department of Health and Human Services or the Federal Trade Commission. And so we're trying to get to a point where we are developing systems so that if you do have that kind of breach, you have done so much as you could to comply with the law so that you can prove these two things in a court of law. That you've done due diligence, which means that you've made reasonable efforts to satisfy the law, and you can actually trace in your software how you go back to the law and what you did to comply with that law, and also that you have met a general standard of care. And lawyers have told us this is a very good idea. So, and why should we worry about it? Well, HIPAA, cost of non-compliance is very high, and we've seen some fines come down this year, some pretty hefty sanctions coming down to different healthcare providers. So it's $25,000 per each individual violation. And some other laws, if you violate some other health, information laws, you can actually end up in jail, which is not a good thing. So it really, I stress this to my software engineering students, we're really working in a very important space here. You've got to make sure that you develop software that complies with law and that protects the information of the people that you are entrusting it to you. We had the American Recovery Reinvestment Act, which made $17 billion available to healthcare providers to adopt electronic medical records. And the goal is to have electronic medical records for every citizen by the age of, by the year 2014. We doubt that's actually going to happen because there's a study that showed that only 90%, back in 2009, only 90% of hospitals actually had electronic health records. So great space to be working in, but we have a long road ahead of us. And this is kind of what HIPAA compliance is like right now. It's like, we're slicing a little to the left. We're almost there, but not quite. But we want to get there. So we've actually analyzed the HIPAA privacy rule and a security rule. And what we found is that there are a gazillion cross-references to other laws. And so one of the challenges is that software engineers try to comply with the law, and then they just assume, well, it complies with other laws too. But the fact of the matter is, if you don't look at the other laws, you might actually be in violation of law. And so these are all of the external cross-references to other laws that exist inside the HIPAA privacy rule, which is a lot to keep track of. And so we've actually developed a taxonomy for how you characterize those cross-references. And we've done a study of them, and we examined 177 external cross-references. And we have some work that my student, Jeremy Maxwell, is working on. But just to give you an idea of why this is challenging. It's hard enough to make sure to comply with one law, much less 177 other references. And here's an example of one of the things that you encounter. So the HIPAA privacy rule says that you have to keep personal health information for 6 years after the last use of that information. And the Privacy Act says that you keep it for 5 years within the life of the record. So again, what do you do? If you're a software engineer, how do you make a determination about this? And so we've developed some heuristics in collaboration with Peter Swire, who's a professor at Ohio State in the law school there, who he was a co-author of HIPAA privacy rule when he was working in the White House for President Clinton. And So we developed these ideas of ceiling rules and floor rules and how you decide what to do when you have a conflict. And the idea is that we want software engineers to have some confidence when you're making a decision, and making a determination about how you implement the software and what rule you're going to comply with, but also flagging those things like, this is safe, you can do this, you can show due diligence and standard of care, et cetera. But on these other cases, you can't make that determination, you need to talk to a lawyer. And that's like a triage that becomes helps us become more efficient in the way we develop software. So some of the heuristics, for instance, would be to store different data that has to comply with the different laws in different places, and you separate it. And you can tag the data that shows this data complies with that law, and some other data complies with other laws. The other thing is if there's an obligation, then you have to do that, and that should take precedence over some privilege that you have. And the law has a lot of obligations, rights, and privileges, and so you have to carefully look at those and examine them. And then the other thing is when there's something you just can't decide and you have to go to a lawyer. I should note that we work with physicians, we work with lawyers, I work with a social scientist in the College of Management. And so one thing that you'll notice is that all of us are working on health, and we're all in different domains. And that's one of the beauties of, I think, the work that we do is that we get to work with people, and we have to work with people outside of our domains, and we're never going to be able to accomplish any great thing. And we're working on all of us are working on important problems. So anyway, here's an example, just example conflicting legal text and summaries of complex. And so the first one is the same example I mentioned earlier, the highlighted one. It says HIPAA you have to retain information for 5 years, Privacy Act says at least 6 years, and then there's another regulation that says at least 30 years if the employee worked longer than a year. Okay, so again, here you want to comply with the most restrictive law, and you want to keep the data separate and use data tagging. So now I want to talk about another case study. I have another student, Erin Massey, who's looking at how do we help software engineers determine if the requirements for a software system, an electronic health record system, are compliant and ready, legally implementation ready. And so he ran a study where we provided students with, these were graduate level software engineering students, with a software requirement specification and a section of the HIPAA privacy rule to determine if they could figure out which ones, okay, these satisfy the law and we can go ahead and implement them, or which ones needed more refinement. And so we compared what they did with what 3 experts did, and one of the experts is a computer scientist and a lawyer. And so we had 3 experts in how do you analyze law and requirements. And then we compared that with an algorithm that he wrote to do metrics to try to figure it out automatically. And the results were very interesting. We found out that the software engineering students are really ill-equipped to do this. And they had a very poor success rate in actually consistently determining which ones were implementation ready or not. The algorithm performed better than the students, and the experts performed better than the algorithm and the students. So this is very interesting because it talks about how do we train people to develop these systems. And it shows the kinds of things we have to be teaching people in order to get to that point where we can protect people's personal health information. And so this takes me to the international. We have a group a gentleman in Zurich who works for a medical device company, and they want to run that study in their company to figure out where do they need to develop new skills so that they can develop these medical devices to make sure that their software engineers know how to make sure that things are compliant. So that's local work that's being noticed globally, and that will affect systems that are being developed all over the world as well. So, so I have to thank the National Science Foundation, Army Research Office for helping us with this work, and my collaborators, as I said, are Erin Massey and Jeremy Maxwell, 2 of my PhD students, and Professor Swire at Ohio State University. And finally, everyone was a compliance person.
Thank you, Dr. You hold this part.
Good evening. Okay. I'm from Africa originally, so my talk is going to start with some of the most challenging global health issues, and then try to relate those to my research, and then show how that has shaped my, my activism or community involvement, since we are talking about local and global issues. So, beginning then with one of the biggest challenges of our time. Some of you, probably all of you, are aware, HIV/AIDS is still a big problem. But many people are not aware of the immensity of the problem, and according to UNAIDS, about 60 million people have so far been infected with the disease since the beginning of the epidemic in the early 80s or late 70s. In 2008, about 33.4 million people were living with HIV/AIDS worldwide. What is more, that same year, 2 million people were infected with the disease. And in that very same year, and again, I said I'm from Africa, and this is one of the things that really made me work on HIV/AIDS and health issues. 67% of all HIV cases, totaling to about 2.4 million, were found in sub-Saharan Africa. This excludes a big chunk of Africa, which is North Africa. And the epidemic has left 14 million orphans in sub-Saharan Africa. Well, that is the global picture. What about the US? And again, many people are not aware. In 2009, about 1.2 million people were living with HIV/AIDS in the US. And the US is among the 15 countries with the highest number of HIV cases in the world. It's among the 15 countries with the highest number. But the problem is, why is it talked about very much? Because the percentage, because we're a huge population of 303 million people, the percentage is very small, but the numbers are huge. And African Americans account for 46% of all HIV/AIDS cases in the US. And as I said, that's why that has hit me home, and that's why we talk about the local component. Well, the Southeast, again, this is a local issue. The Southeast has the highest rate of growth of new HIV cases in the world, in the US. So from the global to the US to the local here in the South. The interesting thing is, I'll talk to you about that. Here is the spread of HIV/AIDS cases globally. You can see that sub-Saharan Africa has the highest, right, in terms of numbers, followed by this Southeast Asia. Come on, Southeast Asia, around this area, and then followed by Latin America, and then Eastern Europe and Central Asia, and then North America, in that order. Now, this map is important because as we look at the next challenge, health challenge, which is malaria, it hits exactly the same regions. The same regions are affected by the same disease, by these two diseases. Okay, malaria. What about malaria? About 3.3 billion people are at risk of contracting malaria worldwide. 30 of the most affected countries are in sub-Saharan Africa, and 5 of those countries are in Asia. The 35 countries combined, 30 in Africa and 5 in Asia, account for 98% of all deaths caused by malaria, right? So that's a problem. Again, global, but we'll see. In 2008 alone, there were over 200 million cases of malaria worldwide, and 1 million people die. And so malaria is a huge problem. It's the 5th leading cause of death among infectious diseases worldwide. It's the 2nd leading cause of death among infectious diseases in Africa, second to HIV. Okay, that is the global. What about the local? In the US, there are annually about 1,500 cases of malaria reported in the US. And again, people are not very much aware. Yet, malaria is supposed to have been eradicated in the early 70s. So it's still a problem. Now, if you look at the map of the distribution of malaria, you see that, go back to the other map, you see that it affects the same regions, the worst. So the same regions that are affected most by HIV/AIDS are the same regions that are affected most by malaria and one other disease. One of my students, a PhD student, is doing a dissertation on malaria, HIV/AIDS, and tuberculosis. And if you look at the areas most affected by tuberculosis, it's the same regions again. Okay, so what does this mean? What about, one more. What about non-communicable diseases? 57 million people die annually because of diseases. 36 of them die from non-communicable diseases. These include diseases like cancer, heart diseases, and so on. They are the leading cause of death worldwide, right? They are caused by things like tobacco, alcohol abuse, unhealthy diet, insufficient physical activity, overweight, obesity, and so on. If you again look at this map, the regions that are affected most by non-communicable diseases are again the same region that are affected most by HIV/AIDS, malaria, and tuberculosis. So, worldwide, these are very big global issues. Okay, what does this mean for me? What about the local connection? Those health problems have made or shaped my research. Most of my research has focused on HIV/AIDS, mostly in Africa, Uganda, Kenya, Tanzania, and so on, as you can see. But I'm now beginning to focus more on the US. In fact, I've just now got a grant, a big grant from NSF to create awareness among black female college students here at NC State using social media, specifically Twitter and the web. Research says that African Americans and Latinos are the most avid users of Twitter, which was very interesting to me. I didn't know until I worked on this grant. And we hope to actually extend this from NC State to other campuses and then possibly globally to sub-Saharan Africa. Again, my interest in this then, not just the health issues, but research has led then me to be more locally involved. For example, I'm currently serving on the board of directors of North Carolina Community AIDS Fund, and I'm actually the treasurer of this fund, which is trying to, again, involve the community to create a force in the community so that we can create awareness in order to reduce the spread of HIV/AIDS. I'm also serving on the board of directors of Stop Hunger Now, whose vision is really to stop hunger in our lifetime. If you are hungry, it means you have less immunity, and if you have less immunity, you'll be susceptible to malaria and HIV/AIDS and tuberculosis, and that is a vicious circle. So that is a nutshell of my presentation. Thank you very much.
And thank you to all our panelists. And now I'd like to open the floor for questions. So Chantel has a microphone. So if you'll raise your hand, and if you have a question, we can bring the microphone to you. I have a question to get things started. So we heard Dr. Cowan talk about a network to monitor disease outbreak, and we heard about foodborne illnesses, we've heard about privacy. I'm just wondering if the panelists have some comments on how information should be, I guess, delivered, and how to maintain privacy while still maintaining access to this important information. For instance, when is it important to report when people have particular illnesses, et cetera, but how do we protect the rights of the individual at the same time? So I'd love to hear from our panelists on that.
Okay, I thought Anne would start with that, but that's fine. Well, you know, I'm in the business of reporting outbreaks, so I'm really not that interested in privacy. You know, our job is to get information out. Actually, the fundamental basis of ProMed Mail is that we are not an official reporting agency. We're a nonprofit organization. And we don't bear the same public health responsibilities that the state epidemiologist does, that the, that the state veterinarian does, where by issuing that official report, it becomes, a basis for legal action. It becomes a fact, essentially, that people are then begin to deal with. We're really on that very cutting edge where there's information out there that may seem like something, and then we act in an iterative fashion. We say, has anybody heard about pneumonia in Guangzhou, China? And we try to go then and iteratively get that information back. So I guess I would answer your question in the sense that information has to be simultaneously open. It should be iterative, but that there is a distinction between official, actionable information and then information that is in the informal sector.
I just have one comment, and I can do without, probably you can hear me without the microphone.
I'll just stand by you.
Okay. In April, I was doing research in Tanzania, and my research, of course, is on very sensitive disease, HIV/AIDS. So when I was going, I had to do IRB, the Institutional Review Board, and they cautioned me, because I was going to do focus groups, cautioned me that I needed to be very careful, and I said yes. So I went and did focus groups, and then I found that one or two, probably three people, among the people that are participants were actually HIV positive. So I told the organization that helped me to recruit participants that I cannot disclose this. However, the interesting thing was that the people, those three people themselves, disclosed to me and actually, openly and said, yeah, we are HIV positive and we want you to know this. That was interesting in that, we tried to say we should not publicize this, but for them, and they said it was so important for them to say it, and they were very pleased when we said, okay, we know, so it was a case of them actually saying openly, and that we are HIV/AIDS. So sometimes it depends on the situation.
Well, one question that I have, and maybe Dr. Antone can answer this, is, are there instances where it's impossible to safeguard the privacy of an individual in a community because once information is published about that person, for instance, if I'm in a department with, I'm the only female faculty member and there's a survey and it breaks things down by sex into male faculty members and female faculty members, then it becomes obvious to everybody that anybody, the answers from the female faculty are my answers. So I'd like Dr. Antone to comment on that.
So this is a real tricky area because on the one hand, we want to share information when there's an epidemic in some case, or when there was the Listeria outbreak a week ago. But by the same token, we really need to, you should work very hard to try to protect your privacy. Tomorrow night in Nelson Hall at 5 p.m. the Department of Homeland Security is sponsoring a Stop, Think, and Connect, I think it's called, to help college students figure out how to protect your privacy and how to protect your information. So the challenge is that there's been a lot of studies that have shown that no matter how much they say, oh, you can't be identified with the data that we're using for health research, that there are studies that have shown, Dr. Latanya Sweeney at Carnegie Mellon has done a lot of work on anonymity, where she's proven that if you have, a record, a database of about 1,000 healthcare records, you can actually figure out and tie those to people by correlating that data with other data that was aggregated and didn't in any way identify you, and supposedly de-identified information. And so it is very tricky. If you're the only person who went in and had a broken leg in an entire week, well, you know what? You are very identifiable. And so it's something to be very careful about. For those of you who are on Facebook, careful about what you put out there. And don't use your social security number randomly or let it get out. I frequently don't sign things that require me to provide my social security number. My father was a victim of identity theft. I don't know if anyone else here has been, but it takes years to clear your name and clear your credit. And if you're in a healthcare situation, you can be denied healthcare coverage for some condition. So it's tricky, and I urge you to do whatever you can to pay attention to your healthcare information. And one of the projects that we're working on is the North Carolina Biopreparedness Project. And this is a case in which there are different state agencies sharing information with the UNC Chapel Hill Hospital and with all of the emergency rooms and all of the EMS services in the state of North Carolina. And there are data use agreements that cover how that information is shared, and each institution that is part of that agreement has to comply with that. And so again, it gets back to making sure that you're doing everything possible to aggregate information as much as possible and to protect that information. But you never really can completely aggregate it.
It's quite the dilemma, isn't it? How to get the information out there and share necessary information about infectious disease, but protect the individual. Yes?
My question kind of piggybacks off the when it's right to share information idea. It's more for Dr. Antone. What do you think of systems like OpenMRS that are working to help healthcare in developing world clinics, but are very open to outside editing of the systems and of the healthcare records? How can you balance the need for healthcare record-keeping systems in that type of situations with the fact that so many people can edit these records?
Okay, so I'm not familiar with the system, so, but if you could tell me just a few more words about where it's used and who edits and whose information is contained in it.
I'm not 100% certain on the details, but I do know that it's basically a program you can download from the internet. And there's really no safeguards once it's downloaded on your computer. There's really no safeguards of who can go in and edit the information. And I believe that it's an internet database system that can be edited pretty much worldwide.
Okay, so this database contains electronic health records in it?
Yes.
Okay.
For specific clinics around the world.
Okay, so that sounds scary, very scary. I'm very familiar with personal health record systems, which is that you govern your own information and you decide to whom your personal health record, to whom you provide or grant access to it, and for what purpose. But this seems like there's probably some people who don't really understand what's going on and don't know that other people are downloading data about them. So if you're just downloading an application that lets you access a database, that's one thing. If you're also downloading data, that's really concerning. And if other people can edit information about you, then that's not a secure system. And it can cause problems for people. If you have random people editing electronic health records, then it may be that you get treated for something that you don't have, or they don't give you the medication that you need because they don't fully understand your situation. So,
is there a way that we can, I guess, provide a record-keeping system to clinics in the developing world that really need that type of system, but without compromising patient security?
you can provide local systems that aren't connected to the internet. That would help clinics tremendously. And then you still need some way, if there is an epidemic or something, to try to get that information out without compromising the privacy of the individual citizens. So there's always a challenge of, in national security, how do you protect security while also protecting privacy, and where's the balance, right? And there's the balance of how do you protect and give the proper health care to people all over the world while also protecting their privacy, right? And their dignity in many cases. It's a
That
challenge.
helps, thank you.
Yeah.
Great question. So when do the rights or when does the freedom of the individual and the protection of the individual, when is that outweighed by the protection of the community?
This question is for Dr. James. Don't know how to say your last name.
Monica Kondo.
Okay. I noticed in your distribution map for the HIV/AIDS and all the other diseases, a lot of the cases were in South Africa, millions of cases in South Africa versus only 310,000 it looked like in Northern Africa. Why is that? Because I think a lot of people have some preconceptions on South Africa as being like richer and healthier and more better than areas in North Africa, which are more poor. Do you know why that is?
Yeah, thank you for that question. When the person who, what's her name?
Lauren?
Lauren, she asked about the cases in South Africa. It's actually not South Africa as such, it is Southern Africa. And Southern Africa then comprises of South Africa, Botswana, Lesotho, Namibia, Swaziland. It's true that these countries have the highest rates of HIV/AIDS. Swaziland has the highest with the 25.6. Botswana has the second highest with 24.6, and so on and so forth. South Africa is very high too. It's over 20%. And South Africa has the highest number of cases, which is over 5 million, which is a lot of people, given that their population is 43. Okay, so why is it so much a problem? In fact, 9 of the countries with the highest rates of HIV/AIDS are in Southern Africa. So that small region, not even sub-Saharan Africa, but Southern Africa. Okay, so I was in June. I spent June with the students doing study abroad in Botswana, and one of the issues that I'm very interested in analyzing, following up on my research in Tanzania in April, I found that one of the issues is that the cultures in Southern Africa have to do a lot with the problem. And a lot of the campaigns have been thinking that, or organizations and government have been thinking that they know what the problem is. They don't, because the issue is so much intricate. It's really cultural practices which are very difficult to understand. For instance, in Botswana, which is doing very well. You talked about South Africa economically. Botswana is doing very well. Botswana is no longer a developing country. It has surpassed. So it's doing economically very well. So condoms are available in hotels, they are in schools. At the University of Botswana, there are condoms. Condoms are available everywhere, but people are not using them. Why? Because of the culture. So before one can really make an impact on the disease, one needs to understand the cultures, and it seems to me that we have not. In fact, I'm very interested in doing research on that. I was doing research in Tanzania about the problem of culture and why there are differences in different regions in Tanzania. And I found that it has a lot to do with culture. So that's the huge problem.
Hi, my name is Caitlin. I recently heard someone speaking about using Google Trends to actually track epidemics and outbreaks, because when people start getting sick, they go and the first thing they do is they Google their symptoms. So I was wondering if you guys could talk a little bit about using the software, and also I guess the privacy concerns with, if you're Googling your symptoms, are you putting yourself at risk for being identified?
Great question. You guys want to take that?
Should I just use from this?
Yes, please.
Well, first of all, thank you very much for the question. That's a great question, because Google did fund us. They funded HealthMap, and they also, were the ones who were engaged in that research, looking at Google Trends. And it really is expanding our notion of how to get information about public health from the traditional. When you step back and think about it, if somebody's sick and they try to get information, and they search on, where's the nearest drugstore where I can get medicine, and it's 3 in the morning, one of two things could be happening. You have an individual who's sick and needs medication, and therefore is a case. Or you have an individual who, is a little worried about their friend, and they want to find out if they're worse tomorrow, and so on and so forth. So that's sort of what we call soft information. It's not confirmed by a bacterial or a viral diagnosis. It's not been seen by by a physician, or, if it's an animal, it's not been seen by a veterinarian. Which is harder information. And what we're realizing is that there's a great sort of elasticity or span of the information that can be used to help us identify where an outbreak is and what its extent and impact is likely to be. The Google Trends research is absolutely fascinating, because they really do predict the influenza curve very, very well. And when you stop back and think about it, most people self-treat themselves for flu. So it's, if you've got the right words to search on, I don't see any privacy issue there unless somebody is, operating on a different level that I operate on anyway.
It's when you're online at 3 in the morning and you start getting ads for cures for insomnia that it starts getting a little creepy.
I agree.
No, it's an issue that many people are beginning to take advantage of. It's a potential for using real-time data, because the truth is, for most outbreaks to be analyzed and finally reported by our public health agency takes a very long time. So they try to get more on real time, but the final outbreak reports take a very long time. So by utilizing data that are coming in, in a way, it's kind of like a citizen science type of thing. People really provide their own data through the web, and so those data are soft data. They're not really monitored in terms of quality or accuracy. We don't have any way of monitoring them in terms of accuracy, but they are data nonetheless, and they can be used together with other data like consumer data, in many cases of foodborne disease, things like sales of toilet paper in a community can give an idea of whether there might be a diarrhea disease outbreak in the community. So those kinds of data are, basically things that the community provides that can be analyzed.
When you visit,
I do want to add one more thing.
Okay.
There was a real-time example of this with H1N1, the so-called quote-unquote swine flu, which is not really swine flu. It's a novel H1N1. There was a company out of Oregon that sort of was monitoring sort of this soft data, and they found in Southern California that, in fact, there was an unusual chatter about location of emergency clinics and so on and so forth. So one of our very first clues came through this sort of soft data with the outbreak of H1N1. And, ProMed Mail is a very internet-based kind of thing where we rely on individuals like Stephen Cunyon to report to us. But this aggregate level data analysis seemed to have identified H1N1 faster than we did. And so you never know, we may be a dinosaur and we just don't know it yet.
When you visit Google headquarters, they have this huge map in the foyer. And it shows that with all these little lights, at precisely where there's a search taking place at that moment all over the world. And one of the challenges is that in developing countries, there aren't a lot of searches. And those are precisely the places where we want to provide people access to information. And so that's something for you all to think about, that there are places in the world that do need information and do need assistance, and where it's not as easy to track these things.
Sir, I have a question for you on the right. You talked about global and local aspects of HIV, AIDS, and other diseases. Have you done research on treatment and access to medicine, and also that local and global aspect of that field?
Most of my research has been really on, because I'm in the Department of Communication. So my area of expertise is communication campaign. How do we design effective messages? So most of my research has been dealing with looking at, actually I started with Uganda because Uganda has been running very effective campaigns. So I looked at how they run their campaigns, what messages, what media did they use, why did they succeed, what about the organizations that were very active, what about public policy and so on. So that those are the issues that I've done research the most. So as far as medicines are concerned, vaccines, I have not. However, what I know is that there's still no cure for HIV/AIDS. And there's research going on vaccines and so on, but not even in the 15 years to come shall we have really a vaccine or a medicine that is that will get rid of HIV/AIDS. So that's an angle that I've not been able to research on.
Great. I think we have time for about one more question. If somebody would like to ask the last one.
I have a question, if no one else has one, about there's a lot of discussion about using SMS texts to relay health information, and I would like to hear from the panelists what their thoughts are on the use of SMS text. I was in Africa this summer. Cell phones are just ubiquitous, even in the forest regions of the world. You will find cell phone usage, so pros and cons.
My experience has been that it was a pro, definitely an extremely innovative benefit in the eradication campaign for bird flu in Nigeria. the way it was used is that if there was a report of die-off or some kind of rumor, people would use a cell phone to call their local health officer, who immediately would use an SMS text to alert the laboratory, plus the field epidemiologist. When the sample was picked up, the taxi driver only got paid when he delivered the sample to, you know, the city, and then the long-haul taxi driver only got paid when they texted the laboratory. Texting was the way that information was transferred, and it was very efficient because they could copy and send multiple key individuals that information at the time. One of the biggest problems that I've found in disease control in Africa and in many other places is that the right information doesn't get to the right people at the right time to make the right decision. And in the case of bird flu, using SMS texts really overcame that barrier.
I have seen, because I've traveled widely in Africa, and the cell phones are actually the mode of communication in many areas, particularly rural areas. They are very useful. We are actually right now doing research on, I don't know whether you know Lake Victoria. This Lake Victoria is the second largest freshwater lake in Africa. And we are doing right now a project of looking at how to improve safety on this lake. 5,000 people die each year on this lake because of storms. So one of the things that we're doing is to find out how we can use cell phones, texting and so on to better, to communicate the information better with the, using or connecting to meteorology officers and the meteorology stations and weather stations. So it has a lot of potential, and the research that I was doing there, this was in July, I found that actually 70% of the fishermen and the boat operators had cell phone. So this means that we can actually use the cell phone then to warn. It's not just warning, but also using cell phone to communicate with on such a to disseminate information about disease. So that's become, it has a lot of potential in Africa.
So I'm not an expert on the SMS use for this purpose. I just know that if you talk to compliance officers in hospitals, especially hospitals that have a medical school associated with them, they say that the most difficult thing for them in terms of complying with HIPAA is the personal devices of the medical students, that when they're doing rounds, it's just easy for them to kind of write it on their personal devices, and the problem is that those are not encrypted. And so that's where a lot of hospitals get into trouble with students or employees who are using a personal device to keep track of some information. No, I'll just use it for a week because and then you lose it, and then you've violated that person's privacy. But that's a different kind of issue than what we were talking about.
Yes.
Hi, I had a question for Dr. James. In terms of, I mean, you mentioned the example of Uganda, where messages have been very successful about reductions of HIV/AIDS, right?
Yeah. Yes.
To what extent can some of this be translated to other places? Let's say in the Southeast, where we do obviously have a problem with HIV transmission. Do you see potential, or are some of those so culture bound that we cannot translate them?
I think the problem is we need to understand the cultures. Even Africa is very diverse. A lot of people think that Africa is the same. Africa is very diverse. So that's one of the issues that we need to, first of all, find out. To what extent are these cultures diverse? How do they understand disease, and how can we then convey effective messages? But on the other hand, some of the things could work. For example, In Uganda, one of the very effective methods was using drama concerts and so on in propagating the message. And that can work not just in Africa, but even in Asia, because the use of music, dance, and drama, and soap opera, that kind of medium works in educating people. So I think that's something that can work very well in all regions. But the key is really to look at the cultures. Yeah.
Well, I wanted to say, first of all, thank you to all of our panelists, and please join me in giving them a round of applause. I would be remiss if I didn't thank Chantal Lapan, who did all of the legwork here in putting this together, organizing everything, making it run smoothly with the Office of International Affairs. So please join me in thanking Chantal. And Chantal, do you want to give a plug for the next Global Issues Seminar?
Yeah, I mentioned earlier that if you'll come on November 8th, we'll have Global Sustainable Livelihoods, and Duarte over here, who's been sitting in the audience, will be up here. So come and listen to what they have to say about innovation and sustainable development. And thank you all for coming out. It's a dreary, dreary Tuesday, so thanks a lot.
Thank you all.